Hello and welcome. Thank you so much for joining us. This is a Cov360 live event, and today we have an exceptional event for you. We are talking about public health innovation, and we are joined by a fantastic panel. Innovation comes in many forms, and our aim today is to really highlight the different types of human ingenuity that enable us to promote individual and collective well-being globally. In a recent World Economic Forum poll, it was stated that 86% of people want significant change to make the world fairer and more sustainable after COVID-19. And this really signals the need to support and share smarter systems and to develop spaces for creative intelligence to flourish. Cov360 is a charity for the advancement of education in public health. And we have a vision of enabling the next generation to rethink and rebuild a future together. So I'd love to get the conversation started now with public health innovation today. At the half past the hour, or 35 minutes past the hour, the panel will take your questions. So please do leave your questions in the Q&A section. And after that, we will introduce their responses accordingly. But I'm going to introduce our esteemed panel now. And I'm very proud to introduce, first of all, Dr. Tracey Chantler, who joins us from the London School of Hygiene and Tropical Medicine, where she's an assistant professor, and she works in the Vaccine Centre Steering Group. And she'll be discussing her vital work on public engagement around vaccines and the recent history of vaccination strategies. And then Amel Najjar, founder and executive director of the Children of War Foundation, joins us from California, and we'll be discussing her incredible work, which does entail technological innovation, with her foundation and her experience with logistics at a board level with international non-governmental organizations. And then may I introduce Dr. Ernest Madhu, who I'll be turning to for the first question very soon. He is the founder, CEO, and chairman of the Heart Institute of the Caribbean, which has inspired work around the world to build resilience and build capacity for low-resource countries. He joins us from Nashville to talk about this work and health planning in Africa, but also providing valuable experience and expertise from the continent. So, Ernest, if I can turn to you, we've just concluded the US election. We spoke about it very briefly last week, but we're not here to talk about that. However, affordable healthcare was really high on the agenda, and it's a vital issue everywhere in the globe. And COVID-19 has really highlighted some of the broader social contexts which impact health. So I want to ask you, Ernest, considering that adults must have access to cardiovascular treatment so that they can care for their children and prevent poverty for the next generation, how does the Caribbean Heart Institute demonstrate and provide affordable healthcare for all? And how can those innovative modalities you so helpfully have been able to deliver ensure it's available in low-resource countries?
Thank you, Theo, for inviting me. I think this has been an excellent group of people. I'm honored to be among them to discuss these innovative issues in public health. You make a very good point, and your question is very timely. If you recall, in my TED Talk many years ago, I make the same argument that the most effective way to protect children from spiraling into a life of poverty and disease is to secure the future of their parents, which are the adults. And how is the best way to secure the future of the parents is to tackle the number one cause of morbidity, the number one cause of death, for the adult population, and that is cardiovascular disease. If you fail to tackle the things that are killing the parents, then you're not going to be able to take care of the children. They will not be educated, and they will be poor, and they will be ill. And so where there's a paradox that is very apparent in global healthcare, 80% of global health resources are utilized by 20% of the world population. And 20% of the population have access, 80% of the population have access only to 20% of the global health resources. In fact, if you're in the bottom 20% of global health, global wealth, your access to global health resources is less than 5%. That is a very inequitable and unfair distribution of resources for the global population. And so what we've tried to do with the Hygiene of the Caribbean is to show there's a time for rethinking, and the new paradigm has to exist that makes sure that the people who need cardiovascular care need to have access to it, no matter where they are. And they should not be consigned to to absence or lack of services just because of their geographical location. So what we've done with the Hygiene of the Caribbean is to leverage advances in technology and knowledge to build the infrastructure for equitable cardiovascular service delivery. And we've done that by making sure that we use multimodality systems that drive down the cost of delivery so that service can be delivered in low-resource nations at a fraction of the cost of similar services in the more westernized world. We also focus a lot on education to build the internal capacity to keep the program sustainable. And once you've made these services locally available, then the next thing is to ensure that they are affordable. And one of the things we've created innovative strategies like HIC Cares membership programs that allow individuals to make a nominal investment for the year and have access to basic cardiovascular care at no cost. So these are some of the things we have done, and we continue to work with so many groups around the world to build similar facilities in different countries. And I'm very proud of that because that has enabled us to reach millions of people just by being cooperative in the way we share our knowledge.
Thank you so much, Ernest. I mean, the data you communicate to us is stark to say that 20% of the world's population is only able to access 80%. And to invert that and to see how under-resourced many countries are. You spoke before we started the call actually about education and technology being crucial in this sphere. I mean, can I ask you to elaborate why this is so crucial in development?
Well, thank you. Without education and without technology, you will continue to lag, behind every other country that is embracing technology and education, right? So we are in a time of unprecedented advances in medical knowledge, right, and science. And to gain advantage of that knowledge, you have to be educated. You have to know what it is. You have to be able to access it. We should be able to leverage technology to drive down the cost of care and leverage technology to break down geographical barriers. So if you combine knowledge and technology, which you gain through education, then you will be able to accomplish things that ordinarily you will be excluded from. So one of our underpinning paradigms is that we focus a lot on growing the local capacity, because that's the way you make the services sustainable. If you train people, then they'll be able to deliver the care locally. Otherwise, you become an export nation, exporting your best talents to other countries in the world. So you create an inverse relationship where the poorest countries of the world continue to subsidize the richest countries of the world. I'll give you an example of what is going on now. You may be aware you're in UK. UK has been aggressive all over developing country, poaching their doctors and nurses to come and fight COVID, right? So they make it so easy for you to go, but if you have the local infrastructure that gives you professional satisfaction, gives you ability to earn enough money for financial independence, then the allure of Western world is going to be less. But it's not equitable in any way, because every country looks inwards when there's a crisis. because of the current crisis, different countries focus on their citizens, and your citizens become dispensable once they have served the needs of the poaching country. And so as long as the developing countries do not have resilient healthcare infrastructure, do not have the opportunities for their citizens to develop professional careers in healthcare, as long as the local governments do not understand the need for consistent and persistent and sustainable investment in the public healthcare space and in education and technology, they will always be vulnerable and they will not move to development. They will always be perpetually underdeveloping.
Thank you very much for expanding that. I think it's good to hear you elaborate on why these issues have arisen. And I think the point which you're making also resonates with something Amel had mentioned before to me in concerning a brain drain that can occur, where the incentives are in other countries to remain, where maybe that needs to be reshaped to have a more sustainable infrastructure locally, as there is a critical need for it. And drawing and turning to you, Amel, you've been working at the extremity of humanitarian context, where the atrocity of war, which we often see through a lens, through television, online, or read in books. But you've had the experience of witnessing some of what's going on and the effects of these atrocities. And Amel, you set up the Children of War Foundation to bring innovative solutions to humanitarian problems, such as deploying teams of doctors to disaster zones and improving local clinical capabilities. Can you tell us a little bit more about how you deliver these forms of transformational healthcare to children and communities affected by war, poverty, and natural hazards?
Sure. Thank you. Thank you for having me. I think the best way to really kind of understand what Children of War has evolved into over 10 years is to just basically start off with what it is that we did initially and what it is that we're doing now. So initially, our mission began with one child who was a victim of war. He was a 9-year-old boy from Iraq. And at that time, our solution of bringing transformational healthcare was to bring children from these regions to the US where we could treat them when care was not available in their home country. And we did that for about 3 years, one child at a time, to at one point we brought groups of 30 children during the summer from Afghanistan. And as you can imagine, the liability and the cost were just too hard to sustain. And then there were other challenges that came with that because, you know, sometimes you're bringing these kids from literally hell and you're exposing them to Venice Beach, Santa Monica, New York, and then you're sending them back. And so although they're physically, you know, healed, there are pretty substantial mental implications, mental health issues that come with it. And so we did that for about 3 or 4 years. And in 2013, at the onset of the Syrian civil war, with so many children requiring specialized care and a backlog of cases that the local surgeons in Jordan couldn't handle, we saw an opportunity to mobilize a team of highly trained academic surgeons, and at the same time to go in and to work with the local doctors and to learn, really to learn about what types of surgeries and cases were going untreated, as well as look into the needs of what the clinicians in terms of training and medical education required. And so at that point, we incorporated education into our mission. And that's when we embarked on our first international surgical mission, where we completed 56 cases in 4 days, really complex cases. And we began to sponsor local doctors from these low resource regions for medical education and training in the US with our academic partners. And the idea with that was that they would go back and they would implement the same teaching practices in absence of our mission. And not sadly enough, but what was happening over the years is that with bringing these mentees and these junior doctors to the US to train, was that many of them would end up not going back, which really defeated the purpose of what we were trying to do. And that goes back to what you had referenced earlier, to the brain drain. And over the years, we did incorporate a lot of the remote mentoring and teaching through your sort of basic communication platforms, which was great, but really not good enough to, train someone. And then you fast forward to March 2020 and COVID-19 hits, and then everything we were doing in terms of delivering transformational healthcare was halted, as we really couldn't mobilize teams like we did prior. And that's when we took a step back and we decided to look at what is it that we were doing, looking from the outside, and saw an opportunity to address the root of the problem as to the reasons why these low resource regions are continuously dependent on foreign aid and outside help, and medical missions that were essentially going in and plugging holes, and ultimately creating more dependency on outside help. And so, to answer your question, how are we delivering transformational healthcare now? In a not a post-COVID era, because we're still in a COVID era, but is that we're focusing on more of remote medical education and training to build capacity and really invest in human capital in these low resource regions. And we recently launched 2 pilot studies for resident education here in the US, in coordination with medical students and residents in low resource regions. And now, with restrictions being eased and being able to practice medicine online, and then being able to share information more securely and exchange it through different software and portals, you see clinicians now being able to bill and see patients without ever touching them. But that's not to say that that this will be the way forward for all of medicine, but it's an alternative to some of the problems. So we're taking this opportunity to now remotely mentor and train surgeons as well as clinicians who would otherwise not have access to it. And although there's a digital divide, a connectivity divide, it's something that we can manage to overcome. Because if you, as Ernest was saying, 60% of the world's population are internet users, and the rest can get access to it. Sometimes it's a matter of content in a local language or just the affordability of it. And so again, what we're doing is we're leveraging our networks here in the US with academic institutions to be able to really bring that education and that training into these regions so that we start investing in local capacity.
Fantastic. I mean, it's inspiration.
I'll stop there. I mean, I can keep going on and on and on, but I wanted to just kind of leave some time there for questions and then answer anything more specifically.
It's fantastic to hear about the work, Amel, and I think it is transformative in the sense that you're providing that local training as well now, and being able to utilize or harness technology to deliver that is crucial in moving forward. And I don't know, are there a few technologies in particular? I think you mentioned before that you're using virtual reality glasses to train practitioners. Is that right?
Yes, so we officially partnered with Vuzix, which has these augmented reality headsets that the doctors really like so far. And they come with 2G software within them. And what's great about it is that it allows the mentee surgeon to engage and operate, have their hands free, and have a mentor surgeon on the other side of the world have access to hear and see everything that they're doing. And at the same time, if they needed to pull up imaging or records, or even put their hands through on the other side of the screen, that mentee could see that guidance. And it's not to say that that's going to be we're going to train full, boarded surgeons like that. But for now, just to supplement that, for example, we're sending a headset to Armenia because there are some really junior doctors there that need help with some of the shrapnel wounds. And so that's doable remotely with a mentor using this technology. And with the VR, you have universities here in the US already, using that instead of a wet lab for testing for residents, where what you're seeing is that they are actually scoring much higher and more proficiently in the exams versus a resident that did a wet lab test. And so the idea behind bringing the VR is that we could remotely train through the VR, and then before we send the troops out to the field, before they do the live hands-on, they have that training before they do the live hands-on with the AR. And again, I mean, this is all very new, but it's very promising, and it's worked out. Next week, or in the next 2 weeks, we'll be doing the first live remote triage in Zaatari camp in Jordan, which will be the first time that's done. And so it'll be interesting to see what happens and how that kind of changes the dynamics of being able to treat and consult kids in these regions.
Amazing, thank you. And it's wishing you well with those trials. I think it's very exciting to hear you adopting this technology and trialing it, because in effect, it's going to improve through that process, through that iterative process of trial and error, and seeing how it can be improved and tailored to different communities.
There was one other point that I wanted to make there in terms of, why we're looking at these low resource regions, and what you had mentioned earlier about, the brain drain, is that if you look at the data that's out there, and for example, like in Sudan and Jordan, Kenya, Haiti, Brazil, is that the students that are fortunate enough to go out and train in the EU and in the US and the UK, 98% of them do not go back. They do not go back. And the 2% that do go back go into private practice because they're not incentivized by the local government. And that by going into local practice, your average person cannot afford a foreign trained doctor. And so that's where a lot of these regions, why they are lacking a lot of these, specific skill sets and expertise.
Appreciated, and it makes it more prescient that needs to be improved on and built on, and I do hope it is. And there's in touching upon working with the local communities is a way and a segue to what I wanted to ask you, Tracey, which is really concerning public engagement and combating misinformation. Now, at the moment, we're at a vital point with the COVID-19 vaccine. And public engagement is very much at the forefront, and we are also at a point where we're trialing new and innovative ways in which we can engage the public in various manners. And because of that being vital to the response and involving communities in the solution to combat misinformation and indeed overcome some of these challenges to strengthen vaccine confidence, I'd like to ask you a bit about your research conducted in the field, Tracey, but also at the London School of Hygiene and Tropical Medicine, who are cutting edge of really innovating in terms of how we understand where we can raise vaccine confidence.
Yeah, thank you, Theo. It's been great to listen to Ernest and Amel as well. So I represent London School, I work at the London School of Hygiene and Tropical Medicine as part of something called the Health Protection Research Unit. And that incorporates kind of a world-leading group called the Vaccine Confidence Project, which is head up by Professor Heidi Larson. And they're kind of, at the moment, they're very in terms of preparing populations, understanding the sentiment around vaccination. They're doing a lot of global surveys and polling to track public sentiment and emotions around current and potential measures to contain and treat COVID-19. So that means that they've been looking, do some social media analysis, and they look at around how different countries, what's coming up in the news and different places, and they'll look at all the analysis. So that's at the kind of quite higher level global polling, and you can follow that in quite a lot of detail on their website and find a lot more out about that. It's really interesting, and they bring up new information about that. So it's very much tracking public sentiment and emotions, which is one way of public engagement. It's a kind of seeing what people are saying through social media sites, Facebook, Twitter, Instagram, also newspapers. They look at all these ranges of resources. But another angles of work that I'm more involved in, and is not specifically necessarily related to COVID vaccines, but also to other vaccines, because I mean, you know, actually the kind of fundamental confidence is in, you know, the routine programs, the other vaccines that your children are offered or young people are offered. And some work that I'm involved with as part of this health protection research unit immunization is kind of filling the gap where there might be a lack of information, for example, on the human papillomavirus vaccine that's now in the UK, but just recently become what we're calling a universal program. Previously it was aimed mainly at girls, but now it's also aimed at young boys. And there are resources out there, information resources, but often they're not necessarily always created with young people together. So with colleagues also from another university in Bristol, we're having a lot of fun. We're working together with youth centres, with 11, 12, 13-year-olds, asking them what are their information needs, and getting them to kind of help us develop small videos and clips to really kind of, again, it's about that tailoring information to the target group, you know, getting them actively involved in developing the messages and getting the information they want. And it's quite intriguing sometimes. Some of the questions they ask are quite in-depth science, and it's great to actually hear that and to then ask them how and what format they'd want that information. Would they, you know, they're creating a small video that could be used in schools. Who do they want to give the messages? And often they will say, we'd love a doctor to come and tell us, or the nurse, and it's just learning from young people what type of information they want. So that's another angle of kind of public confidence that we're doing. At a different kind of level, and this is something that the Vaccine Centre, which is a public kind of community and scientific interest group at the London School of Hygiene and Tropical Medicine. It's public facing, so anybody can join it. You can sign up, you get information. Recently, students of us who are part of that have developed some amazing frequently asked questions videos around vaccines. So how do I know a vaccine's safe? You know, the process that a vaccine goes through, the clinical trials, different phases, phase 1, phase 2, phase 3, phase 4, all these things that we're hearing now in the news, but really kind of creating videos and other resources that are available then for people to be able to use. And another really great tool that Professor Beata Kampmann and a colleague of hers called Ed, and I can't find his surname right now, but they've developed a dashboard also that shows all the different COVID vaccines that are in development across the world at different stages and where they're at. So it's a really great way of accessing information. So we kind of, you can see we're understanding the public at different levels. You've got the public in terms of tailoring information to really specific groups, young people, and working with them. Then you've got the public in terms of people blogging or kind of social media, maybe conspirational, the conspiracy theories that might be out there, and being aware of what people are saying. And then also providing resources that explain the science of vaccinology, which can actually be quite complicated, but can break it down and explain it and create opportunities for anybody to ask questions. Another thing that we're trying to develop as part of our health protection research unit is doing a lot more involving the members of the public in actually helping us think about research priorities. So we have a panel where we will invite people to kind of comment on, well, we're planning to do this, for example, work with adolescents on developing materials, how best should we do this? So we're trying to do more of that. So trying to fit that in at different levels. I hope that's answered some of your questions.
It does, Tracey. I mean, it's a very interesting point, and I want to pick you up on one of them, which was talking about how there's different emotions which are being triggered concerning how we engage. And you said something to me the other day that struck me as quite important, which is vaccine hesitancy and vaccine confidence. And actually us, when embracing a narrative that we have to embrace concerning a potential vaccine being made available, let's say it's endorsed by the World Health Organization, and how do we really ensure that we have enough vaccine confidence amongst the population to have a herd immunity, to have it at the rate of say 80% of the population being able to be vaccinated? What emotions are engaged there that are being effective, may I ask?
I think the conversation we were having was very often there's a lot of emphasis placed on vaccine hesitancy. And I think we have to acknowledge there is vaccine hesitancy. And that can be because people could be scared about something new, something unknown. They could have had a bad experience before, might have even just been a vaccine hurt. But I think we also have to build on the fact that in general, most people are vaccine confident. And I think it's important to build on the confidence, but also acknowledge and create safe spaces for people for places where people can talk to a health professional, a trusted health professional, to share their anxiety. And the other thing I think that's really important is, and something I meant to touch on already, is the places where immunizations are provided. That they are, the health facilities, that they're well supplied, that they're of good standard, that there's a good quality there, so that when you go there with your child or yourself and you're going to have a vaccine, you feel confident. And at the moment, that means that you feel like there's social distancing in place, or that you're not going to be at risk, and you know what you're going to be, what's going to happen to you, and you know how to then that kind of.
Yes, that makes good sense, and I realise that I've and it's my errand as a panelist in also the facilitator in terms of our timing here. But what I'd like to do is go through some of the questions, but also take some of the audience's questions as they come through. And I think you make a very good point about the communication in local healthcare settings being key and crucial to make people comfortable when they're there to indeed adopt and embrace vaccine confidence. I think one point, I think actually what we were going to touch on, and perhaps we haven't quite done that here, is learning from the experience of past pandemics as well. Was that what you wanted to touch on now? I'm going over to Ernest now.
Okay.
Okay, we're going to take some questions from the audience as we go through. We've got a few questions coming through, so that's fantastic to see. But Ernest, I want to turn to you in terms of the local capacity in managing public health crisis. I mean, some of what Tracey's mentioned there is concerning a lack of familiarity with a healthcare crisis. And there's two elements, and it's a rather complex question, but I feel you're well qualified to answer it in part. And considering that COVID-19 has actually drawn a lot of developed and Western countries inward, and there's also been an inwardness in general at a kind of geopolitical level. There are two concerns that I have, broadly speaking, and one is the potential of reduction of outside investment from developed countries, and therefore what advice do you have concerning the healthcare planning that you so eloquently touched upon in the first answer, and indeed what lessons can really be learned from Western countries, from Africa, which are helpful to manage health crises like these?
Yeah, thanks, Theo. Very excellent question. Let me take your question from the other way. The question is, what lessons can Western countries draw from Africa and developing countries? Let me begin by addressing the lesson that Africa and low and middle income countries can draw from the Western world in this pandemic. And then I will circle back to the other one. So the first lesson I think Africa and the rest of the developing world must draw is they need to recognize the nexus between healthcare and economic prosperity and development. They have to recognize that they must build their own internal capacity to make their healthcare ecosystem more resilient to external shocks and not dependent on the benevolence of the Western world. Because when COVID hit, the first thing the rich countries of the world did was to corner all the resources that will be needed to address the pandemic. In fact, there were news reports of personal protective equipment and ventilators that were purchased and paid for shipment to other countries, like Barbados and so on, that were impounded by the richer countries because they needed those for their citizens. So if you are dependent on the benevolence of others, you will not be secure when there is a crisis. So the first lesson for developing countries is to know that they must make sustained and programmatic investment in the healthcare space so that they're not totally dependent on the benevolence of others. Now, if you turn it around and say, what lesson can the West draw? Then you begin to understand when there is a public health crisis, an individualized approach is not the answer. There has to be a collective response where there are programs that are known to be effective that are implemented on a national level so that you can confront the pandemic. Why many countries in Africa have done fairly much better than predicted probably is because there has been more of a national response with a national implementation of proven guidelines that help to stem the pandemic. While in the United States, we have individuals making argument over wearing a face mask despite overwhelming evidence. In many other countries, there is a national response that has mandated the wearing of face masks so that you understand that when there's a public health crisis, individual liberty should not override the collective need to survive the pandemic and secure every member of the population. So that's the way, I will address it. And then to the last part of the argument about how do you prepare a society to respond in the future, there has to be long-term planning in place that recognizes that you have to build a resilient healthcare system to be able to respond. That goes back to what we started in the beginning: education, training, technology, all play a role. But the most important part for me is that there must be a change in mindset. People have to first of all believe that they can do it and not be too reliant on some of the multilateral agencies that train the minds of the public policy makers in developing countries to be content with just the basic.
Thank you very much. I think what you said toward the end as well concerning being in a state of preparedness for a small island nation. I skipped ahead there, but it resonates with how small island nations also responded to this pandemic, in the sense that they had been in regions where you may have been disaster or prone to disasters, and therefore have witnessed it before and can apply that experience to follow those guidelines, as you're suggesting, to put the collective of society ahead in those instances and where possible. I'm going to take this opportunity to follow up with one of the questions that came up, and before I turn over to Amel, a question from Camilla Corbon. She's asked if a research team at the Heart Institute of the Caribbean has explored cultural barriers to access health services? What challenges did heart disease prevention face?
Okay, that's a very good question. Yeah. So these will fall on the broad theme of the social determinants of health. You know, that there are so many things that are not necessarily thought about when individuals look about how to bring good quality healthcare. And culture is a very important part of it. You know, social indices, other things, built environment, the atmosphere where people live and work, all of those things affect the way they seek and access healthcare, or even the way they receive healthcare, right? So one of the greatest, I go back to the way the indoctrination over many, many years, hundreds of years, I go back to the multilateral agencies that have been the advisors of the policymakers in developing countries. The attitude has always been, you know, to have this blinded focus on basic healthcare. That is it. But we're in 2020. If you concentrate, if your focus is only on basic healthcare, it means you're essentially denying your population of the monumental advances in medicine and science over the past 25 to 50 years, right? And so that creates a cultural paradigm that makes people expect and demand less. Mm-hmm. And if you think you demand, if you think you deserve only the basic, you, over time, you're socialized into believing that that is all you should get. And to me, that is the mindset that is the biggest cultural barrier to demanding and accessing. At the end of the day, you know, supply is driven by demand. If no one is demanding it, then no one will provide it. So if the lawmakers, if the governing structures in many places don't have their citizens demanding to have access to high quality healthcare, there are many competing needs. They move their resources elsewhere. But if you've been socialized over time by your advisors and your leaders that basic healthcare is all you need, then that's all you're going to demand. So we actually have our team at the Heart Institute. We have a very important paper that will be coming out in FACET Journal in January, addressing this very, you know, subject, that if you don't have the mindset to demand better, you're not going to get better. But we believe that if you look at what is killing people in almost every country in the world reporting, the #1 cause of death and disability in most countries of the world is cardiovascular disease. But you cannot outrun your gene pool. Even if you focus on creating individuals that are genetically prevented from developing cardiovascular disease, you cannot solve the problem. You have to focus on prevention, but you have to have robust diagnostic and treatment mechanisms in place. That requires that there has to be solid investment in the healthcare space, and there has to be solid investment in education and training. There has to be effort at retention so that you're not just training your people for export. As Amel indicated, you know, majority of the people that giving people scholarship to go overseas is not the answer, because they go, they're not coming back, right? They will come back only if you have the right infrastructure in place for them to practice the type of medicine they have learned and gain professional satisfaction and get financial independence. And by the way, if you make that investment in a consistent basis, in a sustained way, you will drive down the cost of care, because it's not just going to be one person trained in London comes back and there's a monopoly. You're going to have hundreds of people who provide that service, and then you will have ability to negotiate as a group from suppliers so that you can get, because it's cost drives demand drives the cost. If you have 100 facilities in Nigeria, for example, delivering cardiovascular surgery, there's going to be a lot of demand for cardiovascular surgery supplies. It will drive down the cost, and then citizens can afford it. So for me, it is very, very important that we look at mindset as the main cultural shift that needs to take place. And it happens in many developing countries of the world where we've just been trained to believe that these things are not affordable and so cannot happen. We have demonstrated with our program that yes, it can happen. Yes, it can be made affordable and it can be accessible to even the poorest people.
I think is an important note to end on. It can be made accessible. And I like that you've highlighted the social determinants of health and considering them also through the lens of law as well, and the practice of law, and considering the public health more broadly as human rights in varying degrees, if I've interpreted things correctly. But the question which I'd like to raise for Amel, and it is connected, I think, to the answer that you provided, because you're talking about logistics and also the upholding of these rights at a country level. And Amel, I want to ask you about the interactions of humanitarian coordination from your experience. We're now facing a world scale challenge which needs international cooperation, and you've worked on the boards of the IRC and the UN Women for Peace Association. And there is substantial logistical complexity with the work that you do for the Children of War Foundation, and indeed concerning food insecurity and any future vaccine distribution, among other things. And I want to ask, from your first-hand experience, how do agencies interact concerning medical health to meet the needs of the most vulnerable populations to improve global response efforts?
Sure, thank you. Well, first of all, I don't want to be the one that's the whistleblower here. So, but in the real world, agency coordination in a humanitarian setting can be pretty damn wasteful and disconnected. But there are a lot of good things that are happening when you allow organizations to work together, and I've seen that firsthand. There's more willingness today than before, because as we know, resources are scarce and organizations have to work together to get things done. But however, there's still a disconnect between the individuals and organizations with the actual boots on the ground. And then you have the local authorities and the regulatory agencies and international organizations. And I'll give you a couple of examples that I've personally experienced. One is in 2017, our team was in Haiti, and we were getting out on the last flight before the hurricane hit. And there was a lot of medication and equipment that we knew would be required to literally save lives. And luckily, we had access to the International Health City in Dubai, which sent out an aircraft as we were leaving with life-saving medical supplies and equipment. And on their end, it was sent out perfectly. Everything arrived on time in the ports, but the problem was not the actual procurement. It was the actual local government, the port authority, that made it hard to clear items and get them to where they needed to be. And there were so many regulators, some required additional fees, some required additional taxes, some required more hand signatures, some required a rubber stamp from some other office. And so at the end of the day, we had life-saving medication that sat in the port for months before it got out to where it needed to be in these orphanages with children with major ailments. And I think anyone who's been, if anyone's been to Haiti, they understand the disconnect between the local authorities and trying to manage something that really should be a little more streamlined and unified. And now take the blast in Beirut, where we were working with local organizations, and everyone in the world was sending emergency relief supplies. Yet there were cargo planes sitting on the tarmac with ultrasounds and hospital beds that could have saved lives within the first 72 hours. But because of the disconnect between the local agencies and everybody else that wanted to get their hands in it, it sat there until after the fact, and then was distributed to hospitals that weren't necessarily treating the victims that blast. And I mean, it's one big problem that you just have to, you know, basically take on in baby steps. There's not one easy solution. I mean, even here in the US, you have FEMA, you have the WHO, you have the CDC. I mean, look what's happening right now with COVID. And they can't get their act together in a more, you know, cohesive manner. But I think with the world being more connected through social platforms, and that now there's a demand for more transparency, I think that, you know, change will happen. And then, you know, for children of war, what I've seen working with other organizations, other agencies, is that we need each other. So for example, there's an organization in Jordan called CARE, and initially they started off providing care to persecuted Syrian refugees, and now, you know, now they provide care to just refugees in general. And they have smaller clinics that can handle, you know, simple cases, maternal cases, but not the really complex stuff. So, so what they do is they refer cases to us, and same thing with the UNHCR refer cases to us, and that works brilliantly. And vice versa, when we have something that really should be taken care of by the other organizations, it works well. And so, not to say that everybody's disconnected, but there's a lot of it when it's on a bigger scale.
Yeah, I think you're giving us an idea of the complexity involved as well in these logistical challenges. Just merely one operation, let alone global operation, to achieve miraculous results. I do believe it's possible, and I think we're moving in a fantastically fast-moving environment. I want to take this opportunity to follow up. There's one question which has been popular amongst some of the audience in terms of people wanting it to be answered, and specific to your area, Amel, is asking you about health security concerning the increase in urban conflict, and how that is managed and what challenges that presents. I suppose this focuses really into some of your work.
Well, I mean, health security is one thing. I mean, we as an organization can't, you know, take on the mandates of the other organizations that basically provide the security for the refugees and formal encampments. The best thing that we can do is educate. And when I say educate in terms of prevention, awareness, and a lot of the things that we're seeing, especially with, you know, the individuals that have fled under political asylum or persecution, is that it's a delicate situation where well, it's delicate and it's cultural, and so we have to keep that in mind when we're addressing them. I hope that answers your question, but
I think it does, and I think it also even touches on some of the other questions which have been asked. I mean, cultural sensitivity is a critical area and a difficult one, it invites me to take this opportunity to turn to you, Tracey, and really consider vaccine strategies, which of course have to be contextualized amongst the cultural context that they're in. And indeed, you've had experience, which Amel referred to in Haiti yourself. I think it's vital that we raise vaccine confidence, and indeed, I ask you in terms of coordinating vaccine strategies. Can you tell us a little bit more about the recent history of those strategies? What's been effective from your perspective? You're on mute at the moment, Tracey. Thank you.
It's very interesting, this question of politics, because I think it's sometimes a question we shy away from, even when you talk about healthcare and vaccination. But actually, you know, vaccination programs are population health programs. So to a certain extent, they're reaching a large segment of the population. And so they have politics involved, because they're not necessarily individually tailored, that you go to your doctor, I'm sick and I get this medicine, that medicine. They are kind of the population level. So, you know, there's an element that you're required to have an immunization to both, you know, protect yourself, but also to protect others, to raise herd immunity. So I just wanted to put that out there because I think that's actually really important. So vaccination is like a public, it's a social responsibility. It's something that we do one for another as well. And so even with some programs like the school flu program that's given to in England and in the States and other places where children are vaccinated at school, that protects them, but it also provides protection to their elderly relatives and to other people, because they've developed a vaccine which we haven't quite got yet for COVID, is where it's given through the nose, and so you get a kind of mucosal level kind of protection that can limit the transmission. So, but to come back to your question around strategies in terms of past pandemics more, I think what we learned from, in 2009, there was the swine flu pandemic. So it was an influenza virus pandemic, and it wasn't as, by any means, anyway as big as COVID. I mean, COVID is something that probably we haven't seen since the Spanish flu pandemic 100 years ago. However, it also required a lot of thinking about how are you going to provide vaccines to different population groups. And sometimes what people tend to want to do is do mass immunization, that will provide lots of immunizations in one place. But by doing that, you're kind of undermining a point I was trying to make earlier about actually it's useful to go to the places where you normally would go for immunization. So in England, that would be your GP, your general practice. In the US, that might be a physician. In Jamaica, that might be the community healthcare. There's always these different, so strengthening the infrastructure of those places. And in England right now, it's very clear that if we are going to access this new vaccine, the new Pfizer vaccine that seems to be so promising and making everybody happy, is that that needs to be stored at kind of very low temperatures, or minus 70 degrees, they're saying, and therefore you need infrastructure in order to be able to do that. And that infrastructure exists at the moment, it doesn't even exist in our general practices, but you'd have to think carefully through how making sure that you've got that kind of the right word now, but basically making sure that things can go from the freezers to the population quickly enough. And what also from the experience of the swine flu pandemic was that actually when the vaccines were given at GPs or community health clinics, so the local places, people who were at risk felt more comfortable because they knew their doctors, they knew the people, the nurses that were giving them, and they were therefore more likely to take it up because they could tailor the communication once again to that population. So I think that's a key point I wanted to make about that. And I think at a kind of political level, sometimes, when politicians and scientists, and they clearly have to make some very difficult decisions, and we've seen that, and they have to provide some difficult guidance, but often those committees at that higher senior level don't always include people on the ground who are actually the ones who are going to be delivering immunization. And so we need representation of those people and those committees so that then they can help think through what's going to work in a way that will promote confidence on the ground. So that's something else that was found from the swine flu pandemic, is if you involved local people who are actually in the primary care settings or the other settings in kind of informing the best strategies for delivering the vaccine, the best information messages, that was really, really important for that.
Can I pick you up on there and just
Yeah.
to point out to one of the questions which one of the audience members, Mike, would ask, which is concerning the challenges that maybe we can apply here concerning the MMR vaccine and what that presented itself. And indeed, it touches on some of what you've already said, I think, in his question, but where can we learn lessons from the MMR vaccine?
So I'm assuming referring to the kind of Wakefield scandal back in the early 2000s that still lingers on and raises questions in people's minds, and there's still,
Precisely.
I think it's a rapid, the medical, I mean, you need to be able to understand, you need scientists to be able to look at what Wakefield's research was saying, you know, be able to assess the evidence and communicate quickly the counter argument to what they were saying and for what he was maintaining was the case, and act really rapidly on that, and also then train your people on the, you're now beginning to call the front line a lot, to be able to tackle questions that parents might have about this or anybody might have about the MMR, and to reinstill confidence at that level. And what Public Health England, they do yearly kind of tracking of attitudes to vaccination repeatedly, fortunately, in our case, find that parents and adolescents actually trust the healthcare professionals. So it's very much about equipping the people to be able to answer questions.
That's I think so important. I like the engineering term, which is you have to fill the factor of ignorance, and you have to inform the public and involve them in that process of engagement. And I think you made. And
can I say one other thing about that? Sometimes also, which is why I've kind of keep on restating that it's important to emphasize and build and strengthen vaccine confidence. By giving too much attention to conspiracy theories and focusing on them too much, they can spread even more like wildfire. So the best way is sometimes, yes, you might have to ignore anti-vaxxers, but actually spend more time on actually really building. If somebody has questions, they're hesitant, they're not sure, giving them space and time to talk. But there are always going to be the 5% you're never going to persuade, so it's probably not worth. And then it's by providing positive and reinforcing and also showing clearly how vaccines are tested for efficacy, for effectiveness, and providing all that information, being upfront and being transparent. So that's also what the Vaccine Centre is trying to do as well. So yeah, that's another point I wanted to make.
Thank you very much. I think that's a very important point to raise, and we have run low on time, but what I want to do is, I think there's a fantastic question from Victoria, and I'm going to open this up to all of you to answer as succinctly as you can. But she's asked a question for all of you. What 3 things do you think about when organizations look to innovate in terms of health and other industry? Ernest, if I can turn to you first and invite you to answer the question. 3 things which organizations look for to innovate.
Well, you know, it's that's a very tough question. I think I don't think there's going to be one answer that will fit every organization. Every organization will have to look at what their core mission is and what their value is, and then decide on what approaches, you know, what innovative approaches that will help them get to where they're going. But I think at the end of the day, I can give you the things that will probably factor in for every organization in one form or the other. One, it's ideas. You have to be imaginative. You have to be able to run wild with your dreams, you know, imagine it and believe that it can happen. 2, is people. You have to surround yourself with the right people that will drive your ideas, because there's going to be a lot of roadblocks along the way. As Amel had mentioned with, you know, her work in Haiti and other countries, all the regulators that don't have are totally disconnected from what the needs are. Tracey had alluded to that again. So you have to have people who believe in the core mission that will drive the idea forward. And then processes. You have to have processes that are defined, but if you have processes and you don't have people who believe in your processes, you are not going to reach anywhere. So you have to have the right ideas that you believe in as the driver of the ideas. They have to be passionate and committed to it. Passion will fade away quickly, but the commitment will restore your passion. But if you have people who are not believers in your dream, they cannot help you get to where you're going. So you have to have the right idea that you dream of, that is expansive, that you believe in, that you're passionate about, that you're committed to. And then you have to have the people that believe equally, that will help you get there. And then you have to define the processes that will help those people get to where you're going, and you follow those processes.
Beautifully answered. So we have to have the ideas, we have to be committed. And we do need passion, but we need the commitment to restore our passion. But most importantly, what I take from that is you have to dream, and you have to think big and envisage what you can do, and embrace that. Amel, what advice do you have concerning?
Well, first of all, I echo Dr. Ernest, because he put it perfectly with ideas. And just to add to that, but I think it's really important to also exchange information on both sides, because both, you know, these low resource regions that, you know, not need the help, but could use the help, and the opposite can both learn from just exchanging ideas and information. I also think what's really important, and this is, you know, I've learned this from looking, you know, at a high level with the IRC and UN Women and other organizations, and also the Children of War, is that if you want to go in and you're going to try to innovate something or do something, is you first have to look at what are their capabilities now. Because I see a lot of organizations going in and thinking they're going to just implement and start something, not knowing, you know, what the local resources are and what the actual capabilities are. And that's really important. That's something I see happening a lot with different initiatives and programs being implemented. And I think that's about it. Also, just one last thought here is when you, as an organization or even as an individual, wanting to go in and help or get involved in something, is you really have to look at it as an opportunity to involve local citizens in these regions so that they invest in their own human capital to build their own infrastructure. Yes, with your help, with our help, but to really build that infrastructure and the capacity to be self-sustaining and independent. And so that's, I mean, that's really the kind of the holy grail of, you know, of philanthropic and the medical world.
It's a fantastic answer as well. And I think having information on both sides resonates with that last point that you were making, that it really does critically need to be tailored with the community and have the community involved in that process. Tracey, can I ask you the same question? I think it's a great question. 3 key things to think about when organizations are looking to innovate. You're on mute just at the moment. Sorry,
I must learn that. So I think you've got to be really key. What is that innovation trying to address? What are you really kind of, what are the issues? What is the problem? What is the issue? So that you've kind of got a really clear idea, and then you add that imagination that Ernest was mentioning. And I think it's also, when you're bringing innovation, you need to build on strengths that exist already in organizations themselves or in health systems. So not just bring in change for change's sake. And the reason I'm saying that is sometimes in England, we have had a history in the recent past of health systems reforms, and they seem to be just because seems somebody's failing, so let's change it all about again, and then it reverts to what it was. And so it's kind of change for change's sake, rather than actually positive change, building on strengths that exist, and then being innovative where you can find that there's problems within that organization. So you really kind of identify what the problems are. And I think also then, kind of strong leadership and consistent leadership, and that also leaders that listen and bring the team with them.
Fantastic, fantastic. I really appreciate all of you coming forward with these answers. I think the point you're making there, Tracey, with change not for change's sake and strengthening what you have built and where your strengths are is a crucial point among strong leadership. Can I ask you all very quickly, we're going to be a couple of minutes over, but just to ask for your concluding point, and Tracey, if I can turn to you first, and what advice do you have for Cov360, may I ask?
Well, I think I've really enjoyed this actually today, and this sharing, and you obviously, you told me yesterday when we spoke that you kind of came right as an organization because of COVID-19, and I think just keep that going, and creating this space for exchange. I mean, I love the fact that we're talking across 3 different time zones almost, and it's just great. Yeah.
Very much appreciated, Tracey, and we will keep on going. And Amel, can I ask you what advice you have for us and any concluding thoughts you've got?
Sure, and this is just from my own experience, is that you have to be ready for change. I mean, look what COVID has done, right? And just because you started off with one mission or one idea, just know that as we live in an ever-changing world, that you're going to have to make those pivots here and there, and you're going to need to want and willingness to adjust. And so I've seen organizations totally fall apart because they couldn't handle change. And so you have to be flexible and be really creative in terms of how you adjust when things come up.
Fantastic point. Be change ready. I think we will, and hopefully we won't all be stuck in this COVID period for a long time, and we can offer other services. It's a brilliant point. And Ernest, can I turn to you lastly to offer you the opportunity to offer us any advice and indeed any concluding thoughts that you have?
Yeah, thanks, Theo, and thanks again for inviting me, and thanks to Tracey and Amel for making this a very fantastic session. You're doing it right. I think what you've demonstrated, Theo, is that you have to embrace technology and embrace progress. There is an old saying, I don't remember where I heard it, it goes like innovate or die. So the COVID pandemic, kind of like exposed a lot of frictions in the way we do things. And as Amel mentioned, those organizations that were able to pivot and change and adapt to the new realities are the ones that are likely to survive. Those that fail to recognize the new reality may not survive. The disruption that has been created by the COVID pandemic also opened up a lot of opportunities that we didn't even realize were there. It also exposed a lot of inertia that had prevented us from moving forward. One area that was so preeminent was in telemedicine. For many years, different states within the United States, different countries have been spinning around how to regulate telemedicine, how to make telemedicine work. CMS wouldn't pay for telemedicine. There were all kinds of arguments because change is a difficult concept for people to grasp. the COVID pandemic forced that change to happen. When you couldn't cluster people in the doctor's offices anymore, it became clear that this technology that has been here all along could be a great complement to medical service delivery. And we're having all this conference now. I'm in Nashville, Tennessee. Amel's in California. Tracey's in London. And we're all interconnected and having this dialogue. This would never have happened at this pace. Maybe we were able to leapfrog 25 years because of the COVID pandemic. If there was no pandemic, we will be stuck doing things the same old way, even if there were alternatives that we now recognize. So I think, Theo, what you're doing with the program is excellent. I think you have an opportunity to expand it beyond COVID. So this is not going to be a COVID related and COVID it can't be COVID limited. I think there's an opportunity to take this platform and move it forward. And that's information dissemination.
Fantastic way to end, Ernest. And I think indeed this exceptional challenge that COVID-19 has presented has also provided very rare opportunities where we are interconnected, as you say, and we are more aware of our interdependence as well. So I want to thank you, Ernest, so much for coming forward and agreeing to speak today. It's been inspirational, and we'll certainly share what's been spoken about today and hope more people can see it. And Amel, I love the work that you're doing, and I think it's been fantastic to hear more about the Children of War Foundation, and I think some of what you say about being change ready is what you're doing within your organization, which is brilliant. And Tracey, lastly, thank you so much for coming forward at the last minute. Not everybody may be aware of this, but she answered our call yesterday, and we feel that she's done a fantastic job completing this panel. So thank you very much. The last thing I should say is I think Cov360 is very much a we organization. There's over 40 volunteers globally, and we do have a big vision, and none of this would be possible without the extraordinary sense of coming together around a common theme. And we like to call ourselves a networked public, whereby we have a common issue that we want to come together over the online space, but hopefully in person in the future. And as much as I'd love to share our slide deck to show you our plans to pivot from COVID, I won't do it now, but I will finish on a quote. Those of us who draw on collective immunity owe our health to our neighbors, writes Ula Biss. So thank you all for joining us this evening, and thank you to our panelists, to our volunteers, and certainly to all the people who made time to view this. It's been wonderful.
Thank you.
Good night.
Good night, all. Thank you.